Thank you everybody for joining today's webinar, Addressing Opioid Addiction in Acute Care Settings. My name is Jess Samuel and I'm the project coordinator at IRETA. I'll be moderating the webinar today. At this time, I would like to go over some housekeeping items for today's webinar. We would like to encourage you all to participate in the webinar via two methods. First, if you have questions for Dr. Lynch or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. After the first and second sections of the presentation, Dr. Lynch will stop and ask for questions. At that time, we will read aloud any questions that have been submitted. Throughout the webinar today, all participants will be on mute. You're able to collapse and expand the GoToWebinar panel via the arrow button should you choose. 1 hour following the webinar, you'll receive an email with a link to the evaluation and information on how to access your certificate of attendance and continuing education certificates. This webinar has been approved for 1 PCB or NADAC credit. You can also request a general certificate of attendance. Certificates may take up to 48 hours to appear in your profile, so we ask for your patience. I'll go over all this again at the conclusion of the webinar. At this time, we want to go through 2 poll questions. We'd like to get a picture of the demographics of those in attendance. These questions have now appeared on the screen as an interactive poll. Please select the best answer as it applies to you. I'll give everybody a minute to make their selections. So I went ahead and shared the results for today's questions, and it looks like we have a few people that are on that are counselors, therapists, or social workers, and a couple people that have selected other. Thank you all so much for completing the poll questions, and we will be recording the webinar today, and at this time we have begun to record. I'm now going to introduce Dr. Michael Lynch. Michael Lynch is a board-certified emergency physician and medical toxicologist. He's the medical director of the Pittsburgh Poison Center. Dr. Lynch works clinically in 2 Level 1 trauma center EDs and as a clinical toxicologist at 5 hospitals. He has led efforts to improve care for patients with substance use disorders, both in the ED and in the hospital, coupled with connection to ongoing treatment. Okay, Dr. Lynch, if you're ready, I'll hand things over to you.
Great. Thank you very much. Thank you all for joining today. I'm going to be covering kind of a range of topics, and I understand that I originally submitted a title of Addressing Addiction, and I should have specified that truly this would be addressing opioid addiction in acute care settings, hospitals, and EDs. But happy to take questions during the question periods on other types of substance use disorder as well. So I have no relevant conflicts of interest other than my jobs. I don't really receive funding from anyone else. So I'll start with a little bit of background data. I don't think that any of this would come as any surprise to anybody on this call, but we know that overdose deaths rose again in 2017 to over 72,000. We also know, as illustrated in the graph, that really what's driving the ongoing increase in overall overdose deaths is fentanyl and related synthetic opioids, as well as heroin, or synthetics masquerading as heroin. I included on the right side some NIFLS data from DEA. This was actually just released earlier this month from their National Drug Threat Assessment. And really, the idea is not to memorize all of these, but simply to see the variety of different fentanyls that they identified. And this is through 2016, and I can tell you that in 2017, there were more additional fentanyl analogs identified. I think I just saw a question pop up. Is the volume working? Okay. So I'll continue. Please, someone interrupt me if the volume isn't working. What's interesting is despite the rise in overdose deaths from fentanyl and heroin in 2017, we actually saw a decrease overall in heroin use in 2017. And oftentimes I'll use heroin sort of interchangeably with heroin and fentanyl, or heroin in quotations, because certainly where I work and practice in this part of the country, most of our heroin is adulterated with or completely replaced by fentanyl. But nevertheless, we did see a bit of a decrease overall in heroin use in 2017. Whether that's temporary, like we saw in 15 with an increase again in 16, or the beginning of a trend is unknown. But I think that with an overall decrease in use, yet a significant increase in overdose death, just goes to highlight just how potent what's being used is. So there are a lot of different strategies being employed to address the opioid epidemic, and we all work in different sectors of healthcare, and hopefully working all together with a number of different approaches that are all necessary and need to be coordinated, both from opioid prescribing and making sure that we're limiting inappropriate and excessive available opioids while maintaining adequate pain control for those that need it, so not sort of just broad strokes cutting it away from everyone. Harm reduction, so keeping people alive while they are using, and with the hope eventually of getting patients into treatment. And then treatment engagement, which is necessary to get folks into long-term treatment. So preventing withdrawal initially, identifying folks, getting them to immediate treatment, whether that be sort of an immediate inpatient treatment of their withdrawal state or complications, and then transitioning to long-term treatment, particularly with medication. I missed it here. I am trying to move away from saying medication-assisted treatment, as we know that, it's just a medication treatment for a medical disorder, whereas medication-assisted treatment, from a verbiage standpoint, sometimes seem to indicate that it's something different than just a medical disorder that requires medication to provide therapy, but I missed it there on that slide. And then part of it, and part of those language changes, is obviously reduction of stigma, and that is huge and I think indolent. It's hard to recognize probably all the different ways that stigma affect our ability to provide good care. So that's part of every piece of this, from opioid prescribing, pain management, harm reduction, and engagement in treatment. The stigma not only of cultural and social stigma within families, within the healthcare profession, at all levels, it's fairly, it crosses all borders. So I receive a lot of questions about the relationship between prescription opioid use and heroin, and we'll often hear sort of quoted that 80% of injection drug users, quote, started with prescription drug use. And that's sort of true in that it is true that 80% did have non-medical prescription opioid use prior to injection drug use. But I think where it oversimplifies things is trying to create a direct line from a prescription opioid taken appropriately and as prescribed to injection drug use. We certainly know that that can be a route of initiation of an opioid use disorder, but typically the predisposition for a use disorder existed prior to exposure to a prescription opioid, whether taken medically or non-medically. So it's not necessarily where things started. It's just that as exposure and availability exploded in the late 90s and early 2000s, coupled with a certain number of patients with potentially predisposition or risk for a use disorder, it was unfortunately a perfect storm and like gasoline on a fire. However, most patients who do receive a prescription opioid and take it as prescribed, very, very, very few of those patients will go on to develop any kind of use disorder. So just kind of trying to keep that in reference or in perspective, that prescription opioids in and of themselves and taking away prescription opioids won't solve this crisis on its own. As we've seen, prescription opioids have been decreasing for the last 6 to 8 years. Now, obviously, the amount of opioids prescribed are still significantly higher than they were in the early and late 90s, but we are seeing a decrease in prescription opioid availability. What sometimes is less clear is if that's always necessarily a good thing. So are we taking opioids away from those who are functionally on long-term opioids, and might that actually be increasing some risk with turning to illicit opioids? For some, that may be the case. For others, they may actually have improvement with reductions in opioids. Overall, I think it's just a complex issue, and I think we all agree that it had gotten to a point where opioids were way too commonly prescribed, and we are seeing a turn in that. We also want to be thoughtful, though, to make sure that those who are dependent but not misusing opioids aren't left out in the cold by sudden discontinuation or rapid tapering, which are just nuances and thoughts to keep in mind. And I don't want to belabor the prescription opioid point too much. These are just, again, some additional data. Primarily what the opioid data looks at, and prescription opioids in particular, is the risk of ongoing use of prescription opioids at 1 year or potentially 3 years. And the way that that is evaluated is by looking at prescription fills. So this doesn't necessarily represent opioid misuse, certainly doesn't represent illicit opioid use. Certainly chronic pain always starts with acute pain, so some folks may still be prescribed opioids and taking them exactly as prescribed without necessarily a use disorder. So that's where these things can be difficult. But from any provider or patient who is prescribed an opioid, about approximately 6% of them will still be taking an opioid after a year. From the emergency department, that number is actually quite a bit lower. And then again, misuse and addiction would actually be probably a small subset of that small group. That number is actually not very well understood. What the likelihood is of a brand new prescription opioid for a short course, what's the likelihood of developing a use disorder, addiction, or illicit drug use? That number, that percentage is not clearly known, mostly because it's very difficult to study that from a large population perspective. Some factors associated with the initial prescription that would indicate an increased likelihood of ongoing use at 1 or 3 years would be the first prescription exceeding 10 days, and the risk begins to increase after a 3-day prescription. One of the bigger jumps is, not surprisingly, filling a second prescription. So it's hard to have chronic opioid use unless you have ongoing use after the first prescription. Larger amounts prescribed, so that kind of goes to duration or potency. A long-acting opioid, which almost nobody initially prescribes anymore. And then one of the interesting findings, I think, from Shaw was the initial prescription of tramadol carries with it an increased risk of ongoing opioid use at 1 in 3 years, which I suspect is not a property of tramadol itself, but of the prescriber sort of having concerns and therefore prescribing what was deemed to be maybe a, quote, lesser opioid at the outset. So with prescription opioids, I think there is room to go to make sure that we're responsibly prescribing. We could talk a lot more about that, but I wanted to move on and just kind of briefly cover the correlations where they exist and I think some of the unknowns as well. So for those who do have an established opioid use disorder or addiction, what can we do while a patient is in the emergency department or in the hospital? Obviously, we can't be providing that long-term treatment, and if they already have a use disorder, they deserve to have their pain managed, but the initial sort of exposure to an opioid isn't really the concern at that point. So for those folks, we're really focusing on risk mitigation or harm reduction, as well as initial treatment and engagement in opioid use disorder treatment. So the primary risk mitigation strategy is going to be naloxone. Certainly talking about safe storage, preventing others in the home from being able to access their opioids, not driving, operating heavy machinery, watching their children, all those kinds of things, taking benzodiazepines or other sedatives with opioids, those are all important risks that need to be addressed sort of verbally or with counseling while in the hospital or in the ED or primary care office for that matter. But as far as naloxone, something that we can physically provide to patients with opioid use disorders, I just wanted to kind of review some of the benefits of ensuring that folks get that. There is still some resistance, I think, in some corridors about the benefit of naloxone, but the existing data are fairly clear that its overall benefit. So even for patients with chronic high-dose opioid therapy, there is an increased risk of overdose. And this isn't necessarily death, but of overdose, and also an increased risk of death compared to people on lower doses of opioids. So even just being on a high dose, and the CDC recommends greater than 50 to 100 morphine milligram equivalents per day, people should probably be co-prescribed or provided naloxone, either to themselves or to their family or both, to respond to an accidental overdose. And this is cutting out intentional overdoses. So what is naloxone, or the brand name is Narcan? It's actually a very simple drug. It does one thing. It binds and blocks opioid receptors. So if you are not chronically taking an opioid, and I would give this to you or give this to myself, essentially nothing would happen. There really are no side effects with naloxone to people who aren't acutely intoxicated or chronically on an opioid. It acts very quickly, which is important when we're talking about particularly fentanyl and fentanyl analog overdoses. The timing from injection or snorting to somebody stopping breathing could be a few seconds or less than a minute. And once you stop breathing or you're not delivering oxygen to your brain, you can start to have brain death within 5 or 6 minutes and overall death shortly thereafter. So we're really talking about a process where every minute counts, which is another reason that Narcan availability in the community is so important, because even with good and rapid first responder response, it may not be in time. So it acts very quickly, usually within a minute or two. You'll see the reversal effect, sometimes less. It has a short duration of action, which can be problematic with overdoses on things like methadone or OxyContin or other long-acting opioids. But for things like heroin and fentanyl, the duration of action of naloxone is sufficient that people typically don't have repeat sedation following reversal with naloxone. And it can actually be a good thing, because if you induce withdrawal, it means the patient, the individual, would only have to suffer withdrawal for a short period of time before the naloxone begins to wear off. Adverse effects are rare. The primary adverse effects from naloxone administration are withdrawal. Nausea, vomiting, all those kinds of things. Opioid withdrawal does not cause delirium. So anyone who becomes agitated with induced withdrawal either there's something else on board, some stimulant or something else, or they may be upset, angry, but not necessarily delirious. So that's a common misconception with naloxone. And then there have been reported seizures. Again, opioid withdrawal itself is not associated with seizures unless you have some other predisposition to seizures. And then pulmonary edema is another adverse effect that has been reported, but it's unclear if it's the naloxone that's causing the pulmonary edema or the opioid overdose itself that's being reversed, or some combination, probably a combination. It is easy to administer IV, certainly by medical providers, intranasal, intramuscular, subcutaneous, and endotracheal. Usually that's EMS will deliver it that way. So who does the CDC recommend giving naloxone to? Patients who survived an overdose, requesting or having just completed detox or rehabilitation, and that's an important group depending on the timing. Certainly for any of these, a common theme is loss of tolerance. So if somebody has gone through an abstinence-based rehabilitation program, for instance, or the next bullet being coming out of prison and they haven't been using, they're particularly high risk. And even those seeking detox or rehabilitation, we know that recurrence of use is going to be most likely early on. Making sure that those folks have the added security of naloxone is important. Certainly anyone you think is demonstrating behavior concerning for an opioid use disorder, and sometimes naloxone or introduction can be a good way to begin a conversation about your concern in an empathic way, in a patient-centered, caring way, that you're not judging, but you just want to make sure that they have what's needed to not come across harm. And that can be an important introduction. People on both benzos and opioids, even if they don't have a use disorder, are particularly high risk. The high dose we talked about, patients with sleep apnea or COPD, those kinds of things on opioid therapy, and particularly in those last groups, recommending that family members have naloxone. It can be empowering that at least if folks, whether they have a use disorder or just are at elevated risk, family members may be concerned, and at least having that ability to immediately respond can sometimes be somewhat reassuring. So we do find with individuals with use disorder that almost always the naloxone is administered by somebody else with a use disorder or another bystander that is not a family member. Nevertheless, family members should be encouraged, as many overdoses do occur in the home. So what is the effect, the benefit of naloxone? What does the evidence tell us? So we know that there is a reduction in fatalities in communities where the program is implemented, and the more kits that are distributed and the more individuals that are involved in the education to have and administer naloxone are associated with a greater reduction in fatalities in those communities. Alice Wally et al. Did a good evaluation of that in Massachusetts back in 2013. And the other so there is good evidence that it reduces overdose deaths. And the other question is often the cost, because it's not an inexpensive medication. And when looking at the quality-adjusted life years and essentially the cost-benefit analysis, we see that it overall is a very low-cost intervention compared to the benefit and the life years gained as a result of it. So from a population and public health standpoint, it's actually very inexpensive compared to other typical and accepted interventions, dialysis, coronary artery bypass grafting, stent placement, all which have a much higher cost-benefit cost overall. So there is a good argument for that. And then as far as handing them out for bystanders, one study looking at 150,000 naloxone kits provided to lay people showed that more than 26,000 were used for an overdose reversal. So essentially that was 1 in every 6 kits that was distributed was used to reverse an opioid overdose. So with that, why do we recommend it? One, it saves lives, we know that. Patients are less likely to fill a prescription or go to a pharmacy, so we would highly recommend, where you're able, to have naloxone distribution so that you're handing it out. Nasal naloxone in particular is safe and very easy to use, particularly the Narcan nasal spray that doesn't require screwing pieces together or multiple pieces. And it's recommended by the World Health Organization, the CDC, SAMHSA, and the Surgeon General, Dr. Adams, who I've had the pleasure of meeting. It came out with a Surgeon General advisory, which was the first in, I believe, 8 or so years, Surgeon General advisory, specifically recommending naloxone availability across all providers, responders, family, and friends. So I think that just underscores how important it is and how part of a sort of accepted response naloxone distribution is. This slide is very busy, and this will be available, I know, through IRETA, so I don't want to belabor it, but it's just a summary of many of the misconceptions and myths that I often hear when I talk to folks about expanding naloxone administration availability. The most common, and I think even some economists have tried to make the point, is that individuals will be more likely to use opioids, and either more potent opioids in a more dangerous way, because they know naloxone is available. While I'm not saying that maybe has never ever happened, it is definitely not the common scenario. As many of you, I'm sure, know, people who use opioids do not want to ever receive naloxone. We do recommend that if you are going to use in groups, and potentially to have somebody not use and have naloxone available, almost a designated driver type of process, so that you'd be safer and less likely to have an overdose or death related to it. But that's very different than encouraging use. And that's the other typical response, is that naloxone is just enabling individuals to keep using. And again, I think anyone who's worked with patients with use disorders and addiction know, it's not an enabling. It's enabling folks to live, to survive, to hopefully get to a point where they can undergo treatment or be functional, not enabling them to keep using. There is some concern about folks not, refusing to go to an emergency department because of bystander naloxone administration. That is a real concern. I know where I am, we've seen that there continue to be refusals, but not a significant increase in the overall refusal rate compared to before bystander naloxone. But it still remains high. Around 20% of individuals with an opioid overdose will refuse EMS transport after naloxone administration, either by EMS or by bystanders. And while that is a problem, I think it really just raises the need for better engagement in the pre-hospital setting as opposed to taking away that life-saving intervention. And many of the other ones we've already covered. Those are just some references. So just as an example, at our hospital, so where I work at UPMC is a multi-hospital system in Pennsylvania. 17 of our hospitals use the same electronic medical record. So starting in December of last year, our system approved paying for public interest pricing, so $75 a kit, to hand out Narcan nasal spray kits. So each kit has 2 4-milligram sprays. Each one, realistically, is enough to reverse almost any overdose that is going to respond to naloxone. But hand those out to any patient that an ED provider identifies as being at high risk, either because of prescription or illicit opioid use. And it's very much like we give out eye drops and short courses of antibiotics and things like that as to-go packs, and this is the same. It can't be billed through insurance because it's not being administered in the emergency department, so you can't do it under sort of a first dose and then give the rest to go mechanism that sometimes will work. So it either had to be all or none, and our system agreed that it was worthwhile enough to just pay for the kits to hand out to whomever we felt needed it. We also developed an electronic medical record prompt so that providers, as they're discharging somebody, would be reminded to give them the naloxone. And so they get the nasal spray kit with the 2 nasal sprays, and then resources describing, overdose recognition, how to respond, not just naloxone, but how, rescue breathing, calling 911, et cetera. How to administer the naloxone, and we give information on both nasal spray formulations. There's also information on there about what to expect after naloxone reversal, how the individual might feel, and what you can expect there, as well as Good Samaritan rules for our state. And then information on addiction independence and follow-up resources. So that's like a front-back one-pager that goes out with each kit as a resource to the patient, as well as education, interpersonal education, and warm handoff management at that time. This is just from the actual website showing how to give it, just showing how easy it is. It's a blister pack. You pull it off. You put the nozzle in the nostril, and then just depress the plunger. And it's 0.1 milliliters, so it's almost no volume, and it goes very quickly and delivers a high dose. So what we've seen is that it is possible to do. In our first month, only 7 of our hospitals gave it out. By month 7, 16 had, and all 17 have at this point given it out. We've given out 580 kits in 9.5 months. So while we didn't want to add any restrictions or barriers, meaning I did not want anyone to not get Narcan because we were demanding a survey or for them to provide follow-up information. I don't have the number of lives saved, but what we do know is that if we assume that for every 6 kits that we gave out, 1 life was saved, that would be 97 lives, which is certainly I hope it's that many and more. I guess it could be, which would also break down to maybe about $450 per life. And so far, our system has spent a little over $43,000 on that, with great support and ongoing recognition of the importance of those kinds of programs. So it is something that a hospital or a healthcare system can implement with success. It is feasible. This is a weird-looking graph, I know, but what it's showing is our electronic medical record prompt. We had been seeing actually a decline in naloxone distribution, and this was in the summer of 2017, and this is distribution and prescriptions for patients who presented with an overdose, a percent of patients who presented with an overdose. And so since we saw the prompt go live, we see a nice correlation where when the prompt is firing, we see an increase in our naloxone distribution. And so these are just some of the chief complaint triggers. We can't use ICD codes because it's real time. So the chief complaints can be overly inclusive or exclusive, meaning we could miss folks who do come in with an opioid-related issue, or something like withdrawal or detox or drug may not be related. So it's not perfect, but we see a pretty good correlation with naloxone distribution. The other program we have on the inpatient side, and there's some data to demonstrate feasibility of this, and this has been our experience, is a meds-to-beds program. And essentially what that means is we have a multidisciplinary group, and I think for any of these processes to be successful, that's what is required. So internal medicine, toxicology here, palliative care, nursing, pharmacy, social work, case management. We identify high-risk hospitalized patients. We e-prescribe it to an on-site but outpatient dispensing pharmacy. And that's important because that means we can bill insurance, and almost all insurance providers cover naloxone, and many with low or no copay, including Medicare and Medicaid. We dispense that same Narcan nasal spray kit. And for these folks, because they are in-house, we will provide a survey that they can fill out. If they don't, they can still have the Narcan. So if there is a copay, patients are responsible. If it's Medicaid, we're permitted legally to waive the copay, which we do. For those few patients who are uninsured or unable to afford the copay, essentially would otherwise refuse it, we do have a small grant from our outpatient primary care group to just cover the $75 cost of the public interest pricing of the kit, so people will still get it. And this is, we had a few units where we were piloting it before the official start. So this is in just one, Presby and Montefiore essentially function as one hospital. That's the PUH/MUH. So we've seen a general increase in naloxone distribution over that time, and we're working on an inpatient electronic medical record prompt as well. And so some of the data, we've distributed 205 kits on the inpatient side. 43 of those patients were uninsured or required sort of us to give them a kit for free, not run through insurance or Medicaid. But because most did have it covered through insurance, the average cost per kit was actually less than $16 to us or to the system or hospital. And what we found was that we had identified a high-risk population. So more than half of the patients had either received naloxone, knew someone who had, or had to use it, or knew someone who had previously. So that's a pretty high-risk group. And we also saw that 82% indicated that they wouldn't have either filled a prescription or gone to get naloxone themselves under a standing order. So we see that we're getting it into the hands of folks who otherwise wouldn't have gotten it, even with a prescription. And 3/4 indicated that it positively impacted their patient experience, just the fact of having this available to them in the demonstration of caring and concern. So we've had good success, and this will have been expanded to another hospital in our system, and we're looking at system-wide expansion of the same process. So hopefully more information to come on that. Jess, if you guys want to open it up, that's sort of the naloxone base and some of the opioid prescribing, and then we'll be talking about medication therapy in the next section. If there are a few questions, it could probably take a few minutes.
Hi, Dr. Lynch. There is one question that has come through so far, and they asked what the shelf life of naloxone was and how often does it need to be replaced?
Great question. 18 to 24 months, essentially, depending on when you purchase it and so forth. And beyond that, that's what's listed sort of for the FDA and so forth, and that's for that specific Narcan nasal spray product. Beyond that, there is certainly still efficacy, but that's sort of the guaranteed shelf life is 18 to 24 months.
All right, and we have one more. Is there any type of heroin mixed with fentanyl that happened to be resistant to naloxone?
Great question. Actually, I should have covered that in the myths portion. So the answer is no. And there was actually locally in Pittsburgh, a DEA assistant special agent in charge actually misspoke during an interview and referred to, quote, Narcan-resistant fentanyl. That was actually later retracted by the DEA, but unfortunately led to a number of, I think, publications and concern about that. So naloxone works for every fentanyl and opioid that has been identified on the street, including carfentanil. I have personally cared for patients where we confirmed carfentanil in their blood, and they did respond to naloxone, and that is currently the most potently street-available opioid analog. So naloxone does work. The relative dosing may vary some, but what we find is that if people don't respond to 4 milligrams and certainly 8 milligrams of naloxone, typically the issue is that it's either not an opioid overdose, or it's an opioid mixed with something else like a sedative, or it has already been so long that there's already irreversible brain damage, so that even when it's given, it doesn't appear to reverse the toxicity. So there are no currently available licit or illicit opioids that do not respond to naloxone. It's a good question. It comes up a lot.
All right, and we have one more for now. In the survey results that you had showed, N was 95. So does the 61% indicate that the percentage had actually overdosed and now we're receiving a second go-around?
Yeah, so the N of 95 just means that about 110 people declined to complete the survey, or some other logistical reason just meant that the survey didn't get back to us somehow. So that's why within those 205 kits and patients, there were no repeat customers, so to speak. The 61% previously overdosing meant that at some point prior to that hospitalization often was not for an overdose, but for usually some complication of use like infection or something like that, hepatitis, endocarditis, et cetera. So it means that 61% of the 95 people who turned in a survey had either overdosed at some time before that hospitalization, or they knew someone who had, which means that they may not have. And I imagine a lot of us know somebody who's overdosed, but that also sort of emphasizes the point that it's worthwhile to have naloxone available if you know somebody or have known somebody and could reasonably come across an overdose. So I hope that answers the question.
Do we have time for one more right now?
Yeah, I'll take one more.
Okay. How many times can Narcan be administered to a person in one day?
As often as it takes. There is no maximum dose of naloxone. I will say, so in a single treatment episode, in the ER or EMS, if I give 8 or 10 milligrams of naloxone total, say I start with 1 milligram, then I give 2, then I give 4, then I give another 4, something like that, trying to reverse, and the individual is not waking up, I would stop giving it because it doesn't appear to be working, and I would go on to other more effective strategies. If I give naloxone and it works, and either it's a long-acting opioid and the patient resedates or slows down or stops breathing again, or they leave and overdose again or something, it can be given again. There's no downside to it. Obviously, we hope to minimize the number of times that would be necessary, but there is no limit. So I'll go on, and then I can answer questions as long as there are questions at the end, if that's okay.
Sounds good.
Okay. So the next part I want to talk about is medication or pharmacotherapy for opioid use disorder. And as I kind of introduced, MAT or medication-assisted treatment I have used, and I'm just recently reading some articles and things and thinking about it, where since medication is actually the primarily effective treatment, it is more effective than any other single treatment for opioid use disorder, I'm going to try to train myself to move away from saying medication-assisted treatment and just either medication treatment or pharmacotherapy with many other assistances from, cognitive behavioral therapy and those kinds of things. So the pharmacotherapy, the primary treatment options are buprenorphine, or the most common brand name is Suboxone, but I'll try to say buprenorphine, methadone, and naltrexone. Again, the most common brand name is Vivitrol, and I'll specifically say I have no financial interest in any of those brands or drugs. I just included those because they're often used interchangeably with those brand names. And what we know is that treatment with those medications can be very effective. And it's going to be different for different patients, and which medication is appropriate for which patient will certainly vary. But I will say that naltrexone can be very effective for some patients. Typically is not going to be appropriate, certainly in the emergency department setting, and in the inpatient or hospital setting, that I would use very carefully. Methadone, again, in the inpatient or ED setting, I think requires a little bit of extra care, primarily with the transitions of care, because methadone can't be prescribed. Getting somebody into treatment very quickly becomes necessary. And then buprenorphine offers the advantage, at least, of being able to be prescribed, and I'll get into some of the details about how we can do that. But it has other disadvantages as well, as far as induction of precipitated withdrawal and diversion potential. So what we know about adherence, specifically to methadone and buprenorphine, and there is growing data regarding naltrexone, and at least the most recent study I saw, or the most comprehensive in Lancet, would indicate that once somebody is on treatment with naltrexone, it's fairly similarly effective to methadone and buprenorphine, but from an intention to treat standpoint, meaning once you assign people to a pathway, there is a drop-off because initial engagement with naltrexone is reduced compared to the two opioid agonists. But in larger studies reviewing adherence to methadone and buprenorphine, we see reductions in non-medical opioid use, incidence of HIV and hepatitis, reductions in mortality, reductions in crime with improvements in social functioning. Probably most importantly is correction of the actual, so addiction and use disorder is a medical disease. There is biochemical changes in our brains that occur as a result of a combination of genetic, environmental, experiential, as well as exposure to substances that actually changes the way that our receptors, transmitters interact and function. And so regular use of a long-term maintenance medication actually allows for that to be corrected over time, which is why folks who are maintained on therapy for a longer period of time do show reduced recurrence rates compared to folks who are taken off of therapy early after initiation. And then because we all have bosses and people we need to answer to, both insurers and our healthcare delivery bosses, there's a significant reduction in overall annual healthcare costs. And there's a slight increase, as you might imagine, in medication and prescription fill costs. Outpatient visits is fairly similar, but the really important ones are reductions in inpatient hospital admissions, duration of admissions, and numbers of emergency department visits. So because of those reductions, we see significant improvements in healthcare costs and utilization for folks who are adherent to medication therapy for opioid use disorder. And so that's what's the motivation, the driving force behind a lot of, especially insurance and CMS-based strategies to enhance access to care. So how does this translate to the acute setting? There's a lot of discussion about emergency department management, and I know it's long, but I specifically wanted to put in the quotation from the Code of Federal Regulations, or the quote-unquote 3-day rule. And essentially, to summarize it, is as an emergency provider, I can treat a patient with a long-acting opioid, buprenorphine or methadone, if they're in withdrawal in an emergency setting while I'm trying to arrange treatment, longer-term treatment. And I can do that without an X waiver, without my facility being specially licensed as an opioid treatment program for 3 days. It doesn't actually specify consecutive, but for 3 days I can do that. So I can't prescribe it. I can't give people take-home doses if I'm not X-waivered for buprenorphine. But while they're there and physically in the ED, I can treat them with buprenorphine or methadone. And if they can't get into treatment the next day, they can come back and get treated again. And if they still can't get into treatment on a third day, they can come back and get treated again. But I can't do it on a fourth day or after that. It can't be renewed or extended for that treatment episode. So at that point, the concept is to give you adequate time, particularly over a weekend, to make sure that people can get into treatment. It's not ideal. Patients have to go back and forth, but it is possible at least to treat patients so they're not in active withdrawal, sent back out of the ED while awaiting engagement in some sort of ongoing treatment. So from an immediate standpoint, for the treatment of acute withdrawal, buprenorphine and methadone are both work and are superior to clonidine So clonidine is obviously a common non-opioid treatment for opioid withdrawal, often used in conjunction with things like hydroxyzine, loperamide, ondansetron, NSAIDs, acetaminophen, maybe trazodone, other kinds of a cocktail of treatments to address the various symptoms of withdrawal. But in the ED, it's very easy to give, particularly buprenorphine, as just a single dose, and it has a good effect profile compared to clonidine for reducing withdrawal. There was one study done actually looking at 10 milligrams of IM intramuscular shots of methadone with significant improvements in withdrawal as well. Though my experience is that very few EDs are using methadone, primarily in New York. It certainly is legal and can be effective. So there have been studies, and Dr. D'Onofrio in particular at Yale has published several studies looking at ED initiation of buprenorphine. And actually, in her ED, she's gotten all of her physicians ex-waivered, so they're writing 3-day prescriptions. And what they found was that twice as many patients were engaged in OUD treatment at 30 days compared to the groups who were referred but without medication, essentially. And also they identified a reduction in illicit drug use. So obviously very important endpoints. The long-term engagement was not significantly different, but at some point, you know, from the acute care side, the primary responsibility is to get folks to a good treatment program, and then the ongoing retention will need to, you know, be the responsibility of the outpatient provider. So there is good data to support ED initiation of buprenorphine. What I will say is that that relatively few ED providers are ex-waivered, so most are giving it one time, if at all, in the ED and bringing folks back. Though we are certainly encouraging more ED providers to be ex-waivered. Part of that really depends upon having a good landing spot or a good place for patients to follow up after treatment. So just a little bit of background on buprenorphine specifically, because that's where the most data is from the ED side at least. Typical initial dosing is 4 to 8 milligrams of the buprenorphine component. 8 to 16, either daily or divided BID, is sort of the most common maintenance dosing that we see. Above 24 and certainly 32 milligrams per day, you can see this middle graph, you really don't get any additional beneficial effect from buprenorphine. You can be on higher doses if it's specifically being used for pain, but for opioid effect and OUD treatment, doses higher than that are not recommended. It can be prescribed by any provider who has a DEA X waiver, which requires 8 hours of training for a physician or 24 hours for an advanced practice provider, and can be prescribed. There are limitations in the number of patients you can prescribe to at a given time, so depending on how long you've been doing it. And typically, Suboxone or a similar medication that has buprenorphine mixed with Naloxone is what's recommended. And it's important to recognize that the Naloxone, when you take it as it's prescribed, does absolutely nothing. The only reason for the Naloxone to be there is so that it is not diverted for injection use. But for pregnant women and those with documented Naloxone allergies, which I'm often skeptical of, those patients can be prescribed buprenorphine without the Naloxone components. Most common brand name for that is Subutex. But particularly pregnant women is the primary. And honestly, there is some data that suggests that buprenorphine with Naloxone is also safe for pregnant women. But ACOG, American College of Obstetrics and Gynecology, and ASAM both still recommend buprenorphine-only products. The primary adverse effect with buprenorphine, because it's a partial agonist, meaning it doesn't fully give you the opioid effect, but it binds the receptor very tightly, is if you're not already in withdrawal and I give you buprenorphine too early, I can sort of put you into a precipitated withdrawal. And that's really the primary negative effect from buprenorphine. Otherwise, there are very few side effects. The other risk is potentially diversion. It is highly diverted, though it's typically diverted to other people using it to treat symptoms of withdrawal. Some people do use it recreationally or to get high. From a harm reduction standpoint, it's far safer than, say, heroin or fentanyl or oxycodone even, which are our full agonists. What I find that people who admit to diverting it typically are using it to try to manage their own withdrawals in outpatients. So I certainly don't encourage diversion of buprenorphine, but I also don't think it's a bigger problem than for other prescription opioids that aren't limited. For children exposed to buprenorphine, you can get respiratory suppression just like any other opioid, so that is very dangerous, and we do see rising numbers of small children exposed to buprenorphine as it becomes more available. So that is an important consideration for counseling patients regarding safe storage. One of our EDs that sees the highest volume, in fact, almost half of our entire system's opioid-related visits, we started ED buprenorphine. But because most of my partners were not ex-waivered, we started a process of single-dose ED buprenorphine and bringing folks back if they needed to for subsequent treatment with active engagement and referral to outpatient providers, ideally the next day, but as soon as possible. And so that obviously takes a coordinated effort among emergency medicine, toxicology, again, pharmacy, our community providers, and hospital administration. Essentially, if a patient arrives in opioid withdrawal, we treat them with buprenorphine, and then once their withdrawal is treated, then we talk to them about getting into treatment and so forth, and referrals. What we found in the first 10 months of our program is we've had 140 visits where we administered buprenorphine, and that was to 109 individual patients. So about 31 of those visits were return visits, either for a second day or a second and a third day. Very few patients, only about a half dozen, actually had to return for all 3 days. Engagement was difficult to measure. This isn't a research project. It's simply best practice. So because of confidentiality rules, it's hard to know and gather claims, but we were able to work with one of our providers, insurance providers, and see that about 50% of their patients who we engaged in this way went on to fill additional prescriptions for buprenorphine, and we can imagine that with methadone, inpatient, abstinence-based, and naltrexone-based treatment, that number is probably higher overall, which was a significant improvement for our engagement rate. The other part of the acute care is for those who are admitted to a hospital, not admitted for detox or inpatient addiction treatment, but specifically for some other medical or surgical illness. And what we know from the Code of Federal Regulations, again specifically quoted here, is that we are allowed to treat and maintain patients on long-acting opioids, again, without any specific provider licensing or facility licensing as an opioid treatment provider. They can't be admitted for that as the primary reason, but if it's complicating their medical illness, then we can treat with either methadone or buprenorphine as appropriate for patients to treat their withdrawal, their craving, their co-occurring addiction while they're in the hospital. And in places where that's been done, Dr. Leipschitz and her group in Massachusetts documented that when they had a specialized addiction consult team, which included initiation of buprenorphine, their engagement rate in outpatient treatment for substance use disorder was 72% after medical hospitalization, and that compared to 12% of patients who were just detoxified and not maintained on therapy in the hospital. They also identified a reduction in 30-day illicit drug use compared to the detoxification group. Some unpublished data from Boston Medical Center showed a 21% reduction in one-year admission rates, sort of indicating engagement in treatment. And Massachusetts General Hospital showed a 17.5% reduction in 30-day readmission rate. So significant associated both healthcare, individual patient, but then also the system's benefits. So we are doing this here as well. We don't have the outcomes data yet. The construction of a consult team can vary by your institution and available resources. Here, our group is multidisciplinary. We have an inpatient toxicology group. We've actually been providing medication therapy for opioid use disorder, addiction, and withdrawal for a couple of years. We're all X-waivered, so we'll prescribe bridging doses of buprenorphine when patients leave to get them into treatment. We're collaborating now with general internal medicine. Dr. Leipschitz, who I referenced, is actually here now, and we're working with her, which has been fantastic. Our psychiatric group, obviously nursing, none of this can happen without nurses. We have peer recovery specialists in the hospital who are seeing these patients. Social work and case management is so important for getting, identifying where folks are going to follow up. Our pharmacy group to make sure that they understood the rules and regarding buprenorphine, methadone treatment in the hospital, and our information technology group. So we've created order sets and power plans to facilitate medication treatment for opioid use disorder in the hospital, eliminated sort of handwritten methadone order sets and things like that. I think in the future we'll be exploring and are exploring roles of telemedicine delivered services, an application of the ECHO model to assist hospitals and providers who may not have the resources necessary to provide this service. I won't get into it too much, but poison centers across the country have offered a number of different resources, including Naloxone education, identification of trends, real-time assistance in managing overdoses, and drug take-back, public education, opioid safety recommendations, and management of withdrawal with buprenorphine, methadone management guidelines. So inpatient providers can call a poison center for assistance with how to manage those things. The picture is actually one of our medical students from our addiction medicine interest group using a simulation mannequin to demonstrate naloxone administration and overdose to University of Pittsburgh undergraduate students, and this was in their school newspaper. So we're training our students to go out and provide those kind of sessions as well. So where do we go from here? So this is from Science, showing sort of an inexorable overall overdose mortality rate over decades, which has shown a remarkably smooth line over time. So that, you know, and obviously that's in the last 10 to 20 years has primarily been opioid driven, but we also know that cocaine, methamphetamine, things like that are on the rise. What's encouraging is we're starting to see, I think for the first time, a downturn in the last few months. So the end of 2017 and the beginning of 2018, we saw decreases in overdose deaths as well as ER visits, which hopefully will represent the beginning of a trend and not a temporary reduction. And to do that, we have to ongoing efforts to minimize excessive opioid availability, but without limiting appropriate pain management, limiting sources of illicit opioids from Mexico, China, et cetera. Reducing harm, with naloxone and other types of fentanyl test strips, potentially discussion of injection sites and so forth. Reducing the stigma, and that's going to be super important across medical, but just general across our culture. Improved access to addiction treatment, and then preparing for inevitable changes. Cocaine, amphetamines, methamphetamines, synthetic cannabinoids have all been on the rise over the last few years, but have been largely under-recognized because of the ongoing terror of opioids. So just things to keep in mind. And this is what we've seen locally, is that same reduction in ED visits related to opioids. Okay. So I know I'm at or just over time, but I'm happy to take questions for as long as people have them.
All right. So the first one that came in is, would you be able to repeat why you no longer use the terms medication-assisted treatment?
Yes. So the theory or the concept, and Sarah Wakeman and others who talked about stigma and stigmatizing language are really the leaders in this. I've just been reading and thinking and agreeing. But the idea is that the medications are just treatment. They're not necessarily assisting other things. They are the treatment. We don't talk about insulin as sort of medication-assisted treatment for diabetes. We just talk about it as the treatment. And the same with, statins for cholesterol. They're just medication for treatment. We don't call them assisted, even though there's diet modification and other lifestyle modifications. So the idea is just to try to continue to bring opioid use disorder into the fold as a medical illness that we're treating with medication, and then also the evidence indicating that medication is by far more successful than any other intervention. So it's really not assisting other things. Other things are going to be assisting the medication in most cases, not for every single patient, but for most patients. So I think it's subtle, and I know that MAT, medication-assisted treatment, is still the conventional and accepted terminology, and I'm not a crusader. I don't think that's a problem, but that's some of the reasoning or why I'm trying to think about it more when I use those terms.
All right, the next one is, how long will waivered ED docs write for the duration of buprenorphine from the ED?
So if an ED doc is waivered, then there isn't any rule that provides a specific time limit. So 3 days is not a rule for an ex-waivered physician. Sometimes the 3-day rule confuses people. So if you're an ED doc, you're ex-waivered, you can just prescribe it for the duration needed. What I will say is typically I wouldn't recommend prescribing it unless you have a known follow-up identified. And so the idea would be to prescribe enough to get the person to that follow-up, and that follow-up really shouldn't be more than 7 days. I think just in general, induction of buprenorphine therapy, and home induction and initiation, people probably shouldn't be on their own for more than 7 days, and that's at the outside, probably less. Ideally, it'd be 2 or 3 days without a follow-up. So there is no rule that specifically limits it, unless they happen to write for a bunch of patients and actually hit the number of patients they're treating at one time limit, but that would be really unlikely for an ER doctor.
All right, and the last one we have for now is, are you able to share information on opioid addiction in veterans?
Sure. I guess I haven't, I don't work at a VA specifically, so I don't have in front of me or at my fingertips specific veteran-related data. I do know that the VA in general, just from having worked on the pain management best practices interagency task force, I've worked with colleagues at the VA in DC quite a bit, and I know they've been very proactive in trying to address at the same time, which is so important, both pain and substance use disorder. Understand they're not necessarily the same thing, though there is some overlap, and trying to ensure that resources are available for relatively rapid availability of treatment for both, including sort of pain management teams, as well as warm handoff or connections to opioid use disorder treatment. But as far as statistics, I don't have the veteran-specific statistics sort of, at the top of my brain or at my fingertips, unfortunately. Certainly a really vulnerable, in some cases, and at-risk population for a lot of reasons when you consider their specific life experiences in many cases.
All right, well, thank you everyone for your great questions, and thank you, Dr. Lynch, again for such a great webinar. At this time, I would like to go over our evaluation and CEU instructions. You'll be receiving a few emails following the webinar. The first email will include a link to the evaluation information and how to access your certificate of attendance and CEU certificates. Our evaluators are pleased to collect feedback from all event participants. Completion of this evaluation is critical to continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Certificates may take up to 48 hours to appear in your profile, so again, we ask for your patience. Again, we want to thank everyone for your participation today, and if you have any questions, please email us at info@ireta.org. Thanks, everyone.
Thank you.